Good afternoon and welcome to this briefing of the House Health Committee. I am Vice Chair Bonnie Cullison, subbing for my chair, who will be here as soon as she is finished with the meeting that she is currently in. I ask for your patience during this briefing that if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube. Panelists will control your own slides. Before this briefing, all members of the committee were emailed a copy of the presentations. If you do not have these documents, please let the committee staff know and we'll send you a copy. Please note that food and beverages are not permitted in the gallery. We may have drinks at the table just because sometimes these meetings go long. Please make sure to turn off your cell phones and silence them at this time. And remember that if a member doesn't show up in a few minutes, it's because they're likely in another committee attending other official meetings while remaining informed about what happens in these meetings. Please, and to the committee members, please adhere to our usual rules of one question and one answer from the panel, not one question and one answer from each panelist. And keep your question shorter than the answer. Please keep in mind that we have another briefing and bill hearings this afternoon, so we want to be as helpful but expeditious as possible. Today we are beginning our briefing with the nursing home inspection and unlicensed assisted living facilities. Presenting today are Deputy Secretary Meg Sullivan of the Maryland Department of Health and Tia Witherspoon, who is the Executive Director of the Office of Healthcare Quality. So if you will come up to the table, please. Thank you, and you may begin when you're ready.
Great. Thank you, Vice Chair Cullison and committee members. Again, my name is Dr. Meg Sullivan, and I'm currently serving as the Deputy Secretary for Public Health Services at the Maryland Department of Health. And I'm joined today by Director Tia Witherspoon, who's currently serving as the Executive Director of the Office of Healthcare Quality. I want to just start off by saying that when I joined as Deputy Secretary for Public Health Services just over 5 months ago, I knew I have a very wide portfolio of issues under me, including some that I've had the opportunity to talk with you about over the last few days. But I knew that the Office of Healthcare Quality and the issues that we are going to talk about today would be priorities, would also be challenges, and I can say right now those have both proven to be true. I really do, and I know I can say along with Director Witherspoon, really welcome the opportunity to be able to provide an update on where we are with both of these. I think what you will hear today is that we are in a much stronger place than we were a couple of years ago, even last session, but that we still have a lot of work to do. And what you will also hear is that by we, I mean not just the Maryland Department of Health, but how this is really a comprehensive approach. And I know that we'll be joined by a couple of stakeholders, or a couple of partners, I should say, for the second briefing. So if we go to the next slide, so just the agenda, we're going to provide a brief update on the Office of Healthcare Quality, or OHCQ's, progress in completing nursing home annual inspections, an update on the MOU agreement between Montgomery County and MDH to conduct nursing home inspections. I understand I will then pause. We will be happy to answer questions about those and then move on to give background and update on suspected unlicensed assisted living programs. Next slide. So just as a quick overview, which I know many of you are familiar, the Office of Healthcare Quality is the agency within the Maryland Department of Health that determines compliance with state licensure and or federal certification requirements in 47 industries and programs. And just again, as a brief summary, with state licensure, we issue licenses and which authorize the applicant to operate a certain type of business in the state. Assisted living, for example, is a state-regulated program. And then for federal certification, we recommend certification to CMS, or the Centers for Medicare and Medicaid Services, which allow facilities to participate in and seek reimbursement from the Medicare and Medicaid programs for services provided to beneficiaries. And nursing homes are both state and federally regulated, which influences the type of work we do. So specifically, we are asked today to provide an update on our nursing home annual inspection backlog. And again, as I started off by saying, among so many of the other work that OHCQ does, addressing the nursing home inspection backlog has been and continues to be a top priority. What you see on this slide is some data about the historical backlog, which we knew was way too high. You could see we had 172 annual full surveys that were backlogged in December of 2023. We then had made significant progress, bringing that down to 127 in December of 24, down to 36 in September of 25. And then I'm pleased to say, and actually have even a more update, that as of yesterday, we have 10 annual full surveys that are currently overdue for inspection. We had actually initially anticipated being able to complete the backlog by December of 2025. Unfortunately, during the prolonged federal government shutdown that occurred just a few months ago, we were directed by CMS to stop doing annual inspections, although we worked with them to see if we could have any wiggle room, and we're not able to. But we are fully anticipating that all backlog annual surveys will be completed by March 2026, of course, barring anything else that may influence it on the federal level. So I think really did just want to spend a little bit of time also talking about how we went from backlog to compliance. And in particular, we are focused not just on seeing how we got here, but making sure that we stay here, because this is obviously incredibly important for us. So really we'll talk about 4 ways, 2 involving staffing, some of the changes we made around training, and then some improved efficiencies we put in place. So first, in terms of staffing, really when at the heart of the backlog, we recognized that we needed some urgent intervention. And so we're able to secure staffing for contracted certified nurse surveyors that gave OHCQ the flexibility to then be able to build up our own staffing, our merit-based staffing, and have that time to train and transition merit staff to full independence. We know that it takes several months before a surveyor can become independent. And so this contracting mechanism has really allowed us to do that. At the same time, though, we have secured staffing for our merit-based certified nurse surveyors. And you can see since July 1st of 2023, we have hired and retained 39 new long-term care surveyors and currently have for our nursing home program a total of 61 surveyors on staff. We also recognize the importance not only of recruitment, but retention. And so we worked to increase state salaries for 2 grades, which really has positively influenced our ability not only to hire staff, but to keep them. Next slide. We also focused on our enhanced training and efficiencies, really developing and implementing a targeted training program that is aimed at improving surveyor efficiencies, and we were able to decrease surveyor training time from 12 months to 7 months by focusing on those efficiencies in survey completion, but really also ensuring, though, that during those 7 months training, nothing about quality and compliance standards was sacrificed during that training period. We also really looked for our field-based employees, how we could leverage technology, for example, to equip all field staff with smartphones to have enhanced communication, streamline our navigation, again, really increase the efficiency, and make sure that we were doing everything we can to ensure quality as well. Just as one example, we're trying to really leverage internal data analytics tools like Tableau that allows us to very closely monitor our data, really and figure out how we can most efficiently address it, but also do geographic-based scheduling and assign surveys near surveyors' homes. So we're cutting down on things like travel time and additional costs that really allow us to increase the number of surveys completed efficiently. And I think, the question that we're asking ourselves now, again, I think hopefully these slides have demonstrated how much progress we have made, but we need to be able to sustain that compliance. And so again, we'll just reiterate, we are leveraging data. We are using our operational strengthening that we have done to carefully track our survey metrics to identify and address any concerns so that we don't slide backwards. We also know that in 2025, the Maryland General Assembly passed Senate Bill 376 that has required OHCQ to submit quarterly reports on the status of nursing home surveys, reports to local areas on aging, which identify nursing home surveys in the preceding 6 months, as well as annual reports. And we have taken those very seriously and are currently compliant with these reporting requirements and are committed to continuing to do so going forward. The other thing that we are focused on, and I talked about this a little bit before, is on our staffing. We have been able to extend, or renew, I should say, our contract for certified nurse surveyors through FY27, again, to give us flexibility to make sure that we don't further, to make sure that we can not go back into a backlog, but also, again, are focused on our staffing stability, again, talked about targeted recruitment, retention, and succession planning to really try and reduce vacancy-driven delays. And then, again, making sure that we are continuing to prioritize and streamline our workload, obviously prioritizing higher risk complaints, really being focused on efficient scheduling, and ensuring that we're preventing backlog accumulation. And then finally, before I pause for questions, just as a brief update on the MOU with Montgomery County. Again, as a reminder, this was the result of BRFA Act Section 32 from the 2025 legislative session, which, upon request from the county, delegates authority to Montgomery County to conduct nursing home surveys and complaint investigations, requiring Montgomery County to contribute 50% of the costs and MDH to fund the other 50% of the costs. We'll say that over the past several weeks, we have met with Montgomery County on multiple occasions. We have drafted an MOU and a draft statement of work and have sent it to the county. It is currently with them for review. The MOU would formalize this framework that defines shared responsibilities, communication protocols, and areas of cooperation related to oversight and inspection of the county's nursing homes. We look forward to receiving feedback from the county and working with them to move this forward. So with that, I'm going to pause there and answer any questions that we may have on nursing homes and then move on.
Thank you very much. I'm going to open it up for questions. Vice Chair Cullison.
First, thank you, Madam Chair. First, I want to thank you. Tremendous progress, and I really appreciate all the work you've done. I'm excited about the MOU with Montgomery County. We'll see how that works. If it is something that is a model that needs to be expanded potentially or not. I mean, we learn from doing, right? So the question that I have is the staff that you have. I think you said, is it 61 or 67? Does that include the contract surveyors as well, or is that's the merit-based staff?
Yeah, that's correct. That's the merit-based staff.
Okay, so then the 30-some contracts, we're keeping them until July of 27, but they're separate from, but in the meantime, we're continuing to recruit.
Correct.
Okay, what would be the target goal of full staffing for OHCQ?
Yeah, so I think what we're doing right now, Vice Chair Cullison, is we are looking at what our operations would look like now that we don't have a backlog. What the amount of complaints that come in, how are we going to do our revisits? So we're still in the process of figuring out what this new, without a backlog, workload looks like for OHCQ. But we are certainly excited to take on this. This is a great chapter that we're turning. So definitely something we'll be looking at soon, and we are looking at.
Thank you very much. Thank you, Madam Chair.
Thank you. Delegate Morgan.
Thank you, Madam Chair, and thank you for the presentation. And I do want to congratulate you on working through this backlog. I think the concern is now that the goal is to improve the nursing homes, and it seems like we're just running through this backlog. So can you ensure the nursing homes are actually being inspected to a quality that will lead to a better product? And what do you determine as success?
Yeah, well, first, I think that is such an important question, and I do appreciate, I think, the thank yous. I will say that really, I cannot say enough the leadership of Director Witherspoon and the team and how much they are committed to this. I had the opportunity to go out and meet the team early in my tenure, and it is truly a team that does not just care about the numbers, but really sees every single patient as someone in a nursing home and feels very strongly that we need to do everything we can to ensure, right, that we're not just inspecting, but it's high quality. I think first, and hopefully you heard this a little bit during the presentation, that our focus as we talk about efficiencies, we talk about trying to get down the backlog, quality is front and center. And so again, making sure that that has not been sacrificed at all. I think as we go out and do these inspections, both the annual inspections and then the complaint-based inspections, it really is then about, right, making sure that nursing homes are doing what they are supposed to do and holding them accountable. And I can't emphasize enough what a priority that is, but I will turn to Director Witherspoon too to see if she wants to add anything.
Thank you. I think what I would just add to that is when we talk about inspections, it's not just that one inspection where there's a backlog and you go out that one time. We are looking at the plans of corrections and what they put in place, making sure that it's appropriate, making sure that there is sustained compliance, and then we go back out and check. So this is kind of the things that we put in place to ensure that what you say you're going to do, facilities are doing, and not only that, that it's working and that patients are safe.
Follow up. Since there has been such a backlog of nursing homes not being inspected, are you finding that there's an elevated amount of infractions? Because you did work through a huge amount.
Yeah.
Yeah, I think we're not necessarily seeing that there is an increase in citations. Because even though we weren't able to go out there for those annual inspections, we were still in the facilities doing complaint inspections, those targeted inspections. So when there was a high-risk situation going on or immediate jeopardy situation going on, we were in those facilities. So it's not necessarily that we see an increase in citations, but we still are, of course, seeing those citations.
Okay. Well, thank you for the information. Thank you, Madam Chair.
Thank you. Delegate Kaufman, followed by Delegate Shalega.
Thank you, Madam Chair. I always get a little worried with the word efficiency because sometimes that means cuts. So can you talk about how you are embracing these efficiencies while still ensuring that general inspections and complaint-based inspections are thorough? Could you just go into a little more detail?
Yeah, and I'm happy to start, and then we'll turn to Director Witherspoon. So I think first and foremost, really, again, leveraging data and data tools so that we're not duplicating things or having to do things, on paper or multiple times, I think has been a major move forward. I think second, just it would, maybe even seemingly simple things like geographic efficiency, right? So we can get multiple inspections done in one day rather than spending 3 hours in a car. So it is there. These are, I think, some of the things that we have really been able to highlight and can sustain. I think also, though, as you said, making sure that we have very standardized processes that people are following. Again, I think standardization, as long as it is very thorough and doesn't cut anything, is how you can be incredibly efficient. And this is, again, a major focus. But do you want to add anything?
Yeah, I would add, along the same lines that Dr. Sullivan mentioned, one of the things that we have been doing internally is those dashboards that helps me see exactly where we are, what facilities need to be inspected, when do they need to be inspected, when has the last time we've gone out there. So this helps us to also look at this data holistically statewide to see which facilities need a little bit more attention than others. And that's been really helpful as we work through the backlog.
Thank you both. Thank you, Madam Chair.
Delegate Shalega, followed by Delegate Hill. And Secretary Witherspoon, or Director Witherspoon, if you could just pull the microphone a little closer to
Yes,
yourself.
absolutely. Thank you.
Thank you, Madam Chair. Thank you for being here, and certainly better news after the hearing, what we heard last year. But you stopped on unlicensed. Were you going to finish that, or can I ask questions about the rest of it?
My understanding is we're going to,
That's going to come next?
Yes.
Okay, good, because I'm concerned about that. So the kind of piggybacking on what Delegate Morgan said, we're not sacrificing quality. I remember last year you told us these inspections took a whole week, or, it was a prolonged amount of time. So, the survey training time has been reduced by 5 months, about 50%, and focus on efficiencies and survey completion. So we are not sacrificing quality by the hurry up?
No, we aren't. So that was the reason why we bought in those contract surveyors, right? Because they are trained on day one to go in and do these inspections while we get our staff up and running and trained through that time from that 7 to 12 months. So this allowed us not to sacrifice quality because we have those folks in here who are trained on the ground and ready to go while we are getting our staff up and ready to go. So this has allowed us to, what is the saying, fly the plane, the saying. This has allowed us
Build the
to
plane while
build
flying
the
it.
plane while flying. Yes, this has allowed us to do that.
Thank you. My questions are really on unlicensed, so I'll hold them. Thank you.
Delegate Hill, followed by Delegate Ross.
That's all right. I think between the.
Delegate Ross?
Thank you, Madam Chair. So I was looking at this, and I think so let me just ask one quick question. So the issue was totally about resources to do the inspections. There's not any other reason why you fell behind, that just to make sure we're not leaving anything on the table. Like, that was the issue, resourcing, not anything else.
I think there was a couple of issues, honestly. I think resources was the big issue. I think inefficiency was another issue. And also, I think that retention and recruitment was another issue. As you know, most of our surveyors are nurse surveyors, and it's quite difficult to recruit them. And then also, what we found is that to inspect a nursing home, there's specialized training that you have to get SMQT certified training. We haven't had any nurses come in with that training, so there is a lot of ramp-up time to get them trained and certified to be able to go into these facilities. So I think a combination of all of that, along with COVID, was the perfect storm for us to get in the place where we were.
It's good to hear. And then, if I may, just one follow-up. The other question was just thinking prevention, because I was most excited about the sustaining compliance part, because that's where you've really got to be, focused on going forward. So the prevention, to prevent all of this, you've talked about a dashboard and you talked about the metrics. What's your trigger process look like? So at what point do you know we are falling behind, and then you do something? Like, can you just talk through what that trigger is? I'm assuming it's like a dashboard metric, something flashes on a screen that says, we look bad, we're not doing well. and then from there, how do you intervene to make sure we don't ever get back to this again?
So there's actually quite a few different triggers. We have that dashboard, which we talked about. But in addition to that, CMS tracks our data as well. So we are the designated survey agency for CMS for these programs, and they track it very closely. So every quarter, we are seeing where we line up with other states. So I'm not just looking at what we are doing. I'm looking at how are states the same size of as Maryland. How are they performing, and what are they doing? And I measure all of those things by the amount of providers that are coming in, our staffing. What is the staff seeing when they're out there in the fields? Are they having to do a lot of revisits? And is that because what we are saying or the regulation isn't clear? Is that why providers aren't understanding how to care for their patients and be in compliance with the regulation? So there's quite a few things that we look at, but definitely it's those dashboards. Are we getting out there on time? Are we doing our revisits on time? Are we performing the same way that other states are performing that are our size?
And I think that the other thing that I would add, just that I referenced, which I know we take again very seriously, is our public reporting. So the quarterly reports, right, the annual report. So again, we're looking at this on a daily, sometimes even more than daily basis, but knowing that there's multiple kind of fail safes in place too around making sure that reporting is there.
That's good to hear. Thank you. Thank you, Madam Chair.
Absolutely. And just to clarify, those reports are now in statute, so that is a way for us to hold ourselves accountable. Thank you. Delegate Lopez, followed by Delegate Tavares.
Thank you, Madam Chair, and thank you, ladies, both for your thoughtful presentation today and sharing some encouraging staffing news. I look forward to doing a deep dive on all of this within our new subcommittee, and look forward to all the granular information that we'll have in that capacity. I have one kind of top-line question for you, and I know it's not really the focus of your presentation today, but can you give us a general sense of what the surveyors are seeing when they do these inspections? I know reports are forthcoming, but maybe just anything you can share.
Yeah, so nursing homes, it's a little different. So the population in nursing homes are changing. And in some places, our surveyors see what we would come to expect to see in a nursing home, maybe our older, more vulnerable populations in a nursing home. But then in some, there is a younger population in these nursing homes, which makes the care a little bit different. So it's a mix of what we're seeing in these facilities, a mix of issues, a mix of care that's being provided, and also we've noticed that the acuity of care, patients are coming in sicker now, so it's less of them leaving into the community. So we're seeing kind of a mix of everything when we go into the facilities.
Thank you.
Delegate Taveras.
Thank you, Madam Chair. And thank you for the presentation. I think it's in light of a lot of things that were happening over the last couple of years, this became very much highlighted. So in your assessment of these backlogs, are you finding repetitive bad actors? And particularly, what kind, if you are? Let's say, are these people that are crossing state lines, that have these repetitive problems across the board? Or are these individuals that are just acting within the state? And what kind of tricks and trades are you seeing? Are they just moving from state to state, moving and starting operating under different names and such on, so you cannot trace them? Are they not untraceable? So, and if you see a need for, let's say, the need to create some type of a database or an inventory to track these bad characters.
Mm-hmm. So I would say that nursing home operators are a little bit different in that their payment the majority of their payment is coming from Medicare and Medicaid, right? So they are registering with Medicare and Medicaid so that they can accept those payments coming in. So the tracking is, we certainly could use not just a statewide database, but a database that's across the country of bad actors. That is definitely something that would be helpful to all states. We do have Care Compare where we can kind of see and check background information on facilities. But I think for nursing homes, there's a little bit more accountability because their payment is relying on reimbursement from Medicare and Medicaid, right? So they want to be able to submit that billing information and get reimbursed. So they're not typically moving from state to state, but a lot of things that we do see here in the state is buildings that may need a lot of work. That's kind of the thing the overarching theme that we see here in the state is building issues. And unfortunately, it takes quite a bit of capital to renovate these buildings. So they have to do, repairs where they can, but this is the majority of what we see.
Did you have a follow-up? Delegate Hill.
Oh, thank you, Madam Chair. I'm sorry, I thought you had gone out. So a couple of questions. I'm following up really on Delegates Morgan and Ross. The questions were, how do we not have this happen again? And the other part of the question was, how do we make sure that the outcomes are what we want? So you mentioned CMS, there's reporting and oversight from CNS, but that was there before, and we still fell 2 years, 3 years behind. So I'd like to know what's different that we're going to be doing differently so that when the red flags come up, we're actually responsive to them and we don't fall behind. And then if it's possible, I would appreciate it if you guys could provide, maybe Executive Director provide to the committee a copy of what the survey is, because what you described in building issues, I'm thinking, I thought the survey was about operations, and if all you're finding are buildings not being maintained, then I'm very concerned about the questions that Delegate Morgan raised about how we're making sure that the product is what it should be in terms of the people who are residing there.
Absolutely. So you want me to start? Sure. And I can take it. Okay. So some of the things that we are doing to ensure that we don't get back into that place, we put those efficiencies in place. We reduce the training time of our staff, so it doesn't take as much time to get surveyors ramped up and ready to go into the facilities. We are also done a lot of work around retention, so we are retaining the staff that we get. We also put things in place that now we are looking at the amount of immediate jeopardies that a facility gets. We are looking at various metrics that we have at our facilities, in our OHCQ right now, to ensure that if we're seeing facilities that have issues, we are able to respond to those quickly. Now, to address the question.
So that wasn't being done before is what you're saying?
I'm not saying it wasn't being done before. What I'm saying is that OHCQ had a lot to look at. We had some efficiencies that we had to fix internally. I'm saying that we had a lot of facilities that we had to look at. I'm saying that we didn't have enough staff because we were having issues recruiting and retaining that nursing staff. So we did the best with what we had back then. And I think now that we are in a better place, that we have more staff, we have contract staff, we've figured out a way to keep our staff, we are able to focus on these efficiencies and quality things that we weren't able to focus on before because we simply didn't have enough resources to do it.
If I may, that sounds like the solutions and it sounds like they should work. I think the question is, if it's not working with all the new staff, what are we doing to find out if the solutions that are being put in place that sound great are actually working, or if they're not working, that we aren't waiting months and months to discover that they're not working. It's not about, I love the solutions. Mm-hmm. That doesn't mean that they're going to work.
I think it shows in the numbers and the amount of time that we were able to come out of this backlog. We were projecting that it would take 2 to 3 years, and here we are a year later with just 10 in the backlog. So I think it shows in what we're doing and then the numbers that the things that we put in place and the solution is in fact working. And then we do have those mechanisms in place for early detection. So if I see that we are falling behind, if I see that, hey, wait a minute, we are losing a lot of staff, we now have mechanisms in place to address each one of those things that put us in the place where we got here before. And I think what's also important to note is that with the annual inspections, when we go into these facilities, we're looking at everything. We're looking at your boilers, we're looking at the food temperature, we're looking at temperature in the room, we're looking at quality of care issues, we're looking at everything, the total operations of the building. So while we do, in fact, and unfortunately you expect to see some care issues, the overarching theme, the big things that we are seeing that we feel like recurring, I think is what the delegate asked me, the recurring theme that we're seeing is the building issues. It's not the care issues because we are able to put those plans of corrections in place. We're able to go back and follow up and say, hey, did you do this? We're doing revisits to make sure that the care is in place, but those things like building issues that may take a lot of resources, we are seeing that when we come back again, the building may not be in a great state of repair.
Okay,
and
thank you, Madam
If I can just add maybe 2 things. First, when we talk about inspections, obviously we're here focused on OHCQ, which plays a significant role in terms of the regulatory and licensing. But across MDH, there's other work, right, that is being done. Specifically, our infectious disease prevention is regularly working with our nursing homes to prevent spread of disease, right? And we have other places. I know our local health departments are engaged too. So just wanted to know that, right, we recognize it is again, a more holistic approach. The second thing I would say about, in terms of those red flags, I mean, I will tell you, right, with no interest coming back here next year and reporting numbers that have gone in the wrong direction. I started off by saying, again, I knew coming into this role that this is a priority. We speak regularly, looking at the data, but reporting the data transparently and holding ourselves accountable, where I really do believe that if we started to see a backslide, we would catch it early, others would catch it right, and we, again, are holding ourselves accountable through transparency and through putting those systems in place.
Thank you. And I think you're hearing an appreciation of the work that's been done, and also that concern of how do we make sure that this work continues, that we maintain our quality standards, that we maintain that sense of urgency across administrations, because of course, we've had a lot of churn, and we can't speak for, the previous work that was done, but I think there's a desire to partner with you in making sure that we have the tools we need to codify that work, regardless of who is in those seats. And I do see I have a question from Delegate Hutchinson.
Thank you, Madam Chair. And I'm sorry if I have missed this. I'm trying to look at some of my nursing homes on the website here. So you're getting the inspections done, but what can I expect in terms of holding them accountable in improving? And I won't name the facility, but it's one that I get consistent complaints about. So today I see it's at 35%. It's 1 star, 1 star, 1 star, quality, health, along. When I sit here next year, how's that going to improve? Who's going to be held accountable, and how are they going in and making sure that they are actually doing the improvements after these inspections are done?
Yeah, and I think I'll turn to Director Witherspoon, but I will say I think you bring up a very good point that I think we can sit here today and say that we are really feel very committed to that accountability and transparency, but also recognize that the facilities themselves, right, have those responsibilities, and I think making sure that we are partnering with them and holding them accountable as well. Working with CMS, who has some pretty prescriptive steps that we can take, but recognizing that it is a challenge, and it's not just about the numbers and doing a checkbox that we completed the survey, but really looking at the scores. And I don't know if you want to add.
Yeah, I will. It's frustrating and something that people don't like to hear, that we can only enforce what's in the regulation and the standard. So unfortunately, we can't enforce best practices. We can't enforce those types of things, quality standards. I can only enforce what is in the COMA regulations and what's in federal regulations, but we can hold them accountable for what's there. So sometimes you don't actually see the quality go up right away. It takes some time from us going back and revisit and working with them and putting them on a plan of correction. So unfortunately, it's not something that translates quickly as we would like it to.
To follow up, so are you saying that you don't think we have enough teeth to be able to really get in there and hold them accountable? And is that what I'm hearing?
What I'm saying is that we have to follow what's in the state and federal regulation. So if you see something that you feel like we should be able to take a stronger position on that's not in a regulation, that's something that we could certainly work with you on and look into how we can increase those quality things. But I think that it's just important to share with this committee that we enforce the minimum standards that are in the regulations, and we don't have the authority to enforce best practices, and that's frustrating for people to hear, because we want everybody to be following best practices and raising the quality of care where they can.
Thank you, Madam Chair.
And our last question for this panel is from Delegate Warman.
Thank you, Madam Chair, and I kept going on and off deciding whether to ask or not. But I did reach out over the interim to try and meet with you guys to chat, but I wasn't able to get with you guys, so I can actually ask you now. Everything on this presentation kind of seems internal to me. So it's internal metrics, internal training, and internal tracking, and a lot of internal decisions. And other than the requirement that we asked of you last year, is there any other external accountability mechanisms that exist today, not just for, for families, residents, and advocates that want to flag systemic issues before they become crises. I mean, you guys have a complaint system, which is great, but that's after harm has occurred. And I just want to know what other structured and ongoing input does the OHCQ receive from stakeholders on how the system is functioning. Thank you.
Yeah, and I think, and I know I briefly mentioned this at the very beginning, but certainly didn't focus on it in this presentation, but don't take that as, right, that is not an incredibly key part of the work we do across MDH and certainly with OHCQ. I think first you mentioned, right, from public and family members and loved ones, they encourage them to reach out. You mentioned the complaint system, but I think if they are seeing proactive feedback, that is something that we take very seriously and would love to continue to hear. I know, and again, Director Witherspoon can talk in more detail, but we do directly engage with a lot of stakeholders. We get a lot of requests for meetings. Our goal is to say yes to all of them, whether it is providers, whether it is families, whether it's patient advocacy groups. This is something that we need to do because, again, we have a regulatory role. Some of it is very prescribed, but at the end of the day, we all have the same goal, which is, right, to make sure that we have a place for, and I will say this again, but for all Marylanders to age safely and with dignity, and that starts in nursing homes.
Yeah, I think you covered it perfectly. Thank you, Dr. Sullivan.
Thank you very much for this presentation. Did you have a follow-up question, Delegate Worman? Oh, okay. Just saw your light. We're going to go ahead and move on to our second presentation, which is on the unlicensed assisted living facilities. And we really appreciate you coming to our committee because I know this is also of great concern to not just the members of this committee, but the members of this body.
Yeah, and I think, I'll start off again by saying what I said at the beginning, that this is an issue that has been and continues to be a priority that we know is very complex and challenging. We welcome the opportunity to talk about it today and really do look forward to not only the questions today, but the ongoing work and partnership because we know that's what is needed. We do have slides.
We do, and I have messed them up, and I don't know if anybody can help me. Thank you so much. I am so sorry.
That's all right.
This is why they don't let me do this.
We acknowledge that technology can be difficult, and we will give ourselves a little bit of grace.
Yes, that would. Thank you.
Okay, thank you.
Okay. So again, we'll just provide a brief overview of the suspected unlicensed assisted living programs and the work that we are doing, and then again, welcome the opportunity for questions. So just as a quick snapshot, there currently are 1,617 licensed assisted living programs in Maryland. And all facilities that are assisted living facilities that are licensed must comply with COMAR 10714 to be licensed. Those regulations were actually recently updated and put into effect last year. And again, OHCQ plays a critical role in both the regulation and licensing there. We also have the authority to investigate unlicensed assisted living facilities or facilities that are suspected of providing services that are consistent with what would be classified as an assisted living program, but does not currently licensed. By nature, unlicensed facilities are not registered with the state. And so we can only investigate based on information that is shared with them. And that is why, and you'll hear me stress this again throughout the presentation, it is critically important that anybody who has any concerns or complaints about what may be a suspected unlicensed assisted living program that is reported to OHCQ, and then we act upon it. Next slide. And just as a little bit of data, we receive currently an average of about 8 to 10 complaints per month related to suspected unlicensed facilities. Just as a snapshot, this is a small subset of about the 1,080 complaints that we receive per month across all of the programs that we regulate. For the suspected unlicensed assisted living programs, most complaints involve private residents, and cannot stress enough that we take these complaints very seriously. We investigate them and really believe that every Marylander's health and safety is paramount, and we use that as our underlying core when we go out to investigate. Just as some brief data, in fiscal year 25, we received 120 complaints about suspected unlicensed facilities with some duplication, so it ended up involving about 92 facilities. Of those, we were able to determine 13 to be an unlicensed assisted living program, again, meaning that they were providing services consistent with an assisted living program but did not have a license to do so. We issued notices of violation to all 13, and I'll talk about the notices of violation a little later, but we'll say that during FY25, in our investigations, we did not find any evidence of abuse, neglect, or exploitation at those facilities. In early FY26, so this is July through December of 2025, we have received 63 complaints that involve 51 facilities, again, accounting for duplications. Of those, 10 have determined to be unlicensed assisted living programs. We have issued notices of violation to these 10. We do, of the 51 facilities, we have 3 investigations still ongoing. And of those programs that we have completed our investigations, we have identified 2 instances of abuse and neglect with referral to the Office of the Attorney General. Just to briefly outline our investigation process, we'll just again emphasize this is one of our priorities. So when we do receive a complaint, and that complaint comes from many sources, whether it be neighbors, family members, healthcare providers, partners, and others, we review the information and any available records to confirm whether the facility already does have a license, whether it is with an assisted living program or other program within the state, or has an application pending. If they do not, we go on site to conduct a visit to try and verify whether individuals are receiving services that require an assisted living license. If, and I will say this is true for any facility, whether licensed or unlicensed, if we identify any individual in need of medical attention, we are contacting EMS immediately. If we suspect abuse, neglect, or financial exploitation, we contact the appropriate agencies immediately, whether that is our emergency medical services, whether that's law enforcement, adult protective services. And this is something, again, that we do across the board. Next slide. If the facility does not have a license or a pending application, we issue a notice of violation. And again, in those instances where there is not an abuse, neglect, or financial exploitation that is identified, the statute allows 30 days for the provider to come into compliance by either relocating the residents or applying for a license. On the 31st day, we then go back to determine whether the provider submitted a complete licensure application or safely relocated all of the residents. If the provider remains out of compliance, we issue an additional notice of violation and also have the discretion, again, according per the statute, to impose a civil monetary penalty. If the provider submits an application within 30 days, they are considered to be working towards compliance per the statute. And during this time, OHCQ does not compel relocation of the residents unless there is an immediate threat to health or safety, because we do want to ensure that residents have a place where they can safely be during this time. So just a brief overview of the statutory language. This falls under statute 19-1809, which in 2023 was amended to strengthen enforcement against unlicensed assisted living programs through a bill that was sponsored by the Office of the Attorney General and supported by the Maryland Department of Health. This provides statutory authority to investigate unlicensed assisted living programs, issue violations, refer for a criminal prosecution, and seek injunctive relief where abuse, neglect, or financial exploitation are present or where operators refuse to cooperate. And again, just to reiterate, and how it says in the statute, if there is no imminent threat, the statute does provide a pathway for facilities that can allow an operator, in certain circumstances, to submit a complete licensure application within 30 days. We will note, and I think this will come out, we'll talk about this in some of the discussion, but the statutory language does remain narrowly tailored. The allegation must be credible in order to refer to the Office of the Attorney General. Also, unlike licensed facilities are not subject to the same right of entry provision. So if we do go out and investigate a complaint and entry is refused, our authorities are more limited than they are with licensed facilities. And again, we'll talk about that in a bit. So we, I think, fully recognize the challenges and complexities of this. I have mentioned a few times that this has been and continues to be priority. And over the past several months, we have taken several steps to strengthen our facility oversight functions. This includes just overall, and what I talked about during the nursing home presentation, getting OHCQ in a stronger place operationally. Talked about how we have increased staffing, and this is across the board. We have addressed backlogs and inspections. We've strengthened our training and quality assurance and developed operational efficiencies, and again can say here today that OHCQ is in a stronger place. I started off by talking about the importance of public reporting. So we have recently launched a public-facing link on the OHCQ website to directly facilitate the reporting of suspected unlicensed facilities. Recognizing, though, that a website is not the only way that people may report, we do receive complaints by phone, fax, and regular mail as well, and are looking for opportunities to really make sure that people are aware of how they can report and that it is as streamlined as possible. We have also really, over the past months or several months, been strengthening and standardizing our internal policies for unlicensed assisted living programs to ensure that we are operating within our full statutory authority for all investigations while continuing to prioritize the safety and well-being of residents at facilities. I talked about some of those nuances in the statute. We are really taking a hard look and looking at where some of those gray areas are, how we can make sure, again, that our policies are as strong as they are or can be. Again, though, continuing to prioritize safety and well-being of residents and facilities, and understanding that our overall goal is to increase the number of licensed assisted living programs in the state. I also do want to mention that talked a lot about how this is a holistic approach. OHCQ has an important role here, but certainly we have many partners that also really have an important role to play as well. And so on January 27th, MDH, in collaboration with our partners at the Department of Aging, launched because it's ongoing, an interagency work group on unlicensed assisted living programs. The goals of this work group are first, to increase the number of licensed assisted living programs to safely serve Maryland residents, working with unlicensed facilities to come into compliance wherever possible, while still holding those accountable where we see those evidence of imminent threat and lack of compliance. The second is to improve our interagency coordination to streamline processes, respond to needs of residents and health providers, and prevent negative outcomes. I talked about how internally we are looking at our own policies and protocols to make sure that they are as strong as possible, but we also recognize that for many of these facilities, it requires a lot of interagency coordination, whether with our Office of the Attorney General, our partners at the Maryland Department of Aging, our partners at Department of Human Services and Adult Protective Services, our local agencies and government, our local government agencies and partners, and so many others, and this is what we are trying to do with this work group. We are also looking to recommend policy, operational, and regulatory actions that may be needed going forward to further strengthen the oversight of these facilities and the state's ability, again, to ensure that there is an adequate number of safe and affordable facilities and services for Maryland's aging population. Next slide. Just as a couple other next steps, we are also developing a training for nursing home and hospital providers on proper discharge planning practices, recognizing that when patients are discharged from facilities to programs, making sure that they are licensed and that they are providing the appropriate level of care that patients should need to be receiving. And we have plans to implement this in the coming months. Also, for specific cases, when we do encounter cases that are the kind of a gray area in the statute, we have already started enhancing collaboration with our agency partners on case review and site-based enforcement and plan to continue to ramp that up more forward. And then already talked about how jointly with the Maryland Department of Aging, launching the time-limited work group that has already held its first meeting and plans to meet regularly going forward, and will issue a public report, making recommendations on additional policy, operational, and regulatory actions. So I think I'll just end there just by, again, emphasizing this is a priority for us. We know that it is complicated, that it requires a holistic approach, and really are focused on, first and foremost, increasing the number of licensed assisted living programs to safely serve Maryland residents, We are improving interagency coordination to streamline processes, respond to needs of residents and health providers, and prevent negative outcomes, and then working holistically across the government to address the broader issue of ensuring adequate numbers of safe and affordable facilities and services for Maryland's aging population. And I think with that, yes, I will pause, and we are available for questions.
Thank you very much. And because we still have a presentation from the Office of the Attorney General as well as from Lifespan, I'm going to ask that we hold our questions till we have the full panel. And I also want to just acknowledge that we have students from Anne Arundel Community College here in the gallery, or they were in the gallery, learning about the legislative process. And this is a really important and essential briefing for them to be able to participate in. So I'm going to ask that that Lisa Martz from the Office of the Attorney General, if you can approach the table, and if I can ask the department if you're available to stay for questions.
Yes.
That way we can make sure that that we can have the full picture of the concerns we have around unlicensed settings.
I would say good afternoon. I'm Lisa Martz. I'm the Deputy Director of the Maryland Medicaid Fraud and Vulnerable Victims Unit at the Attorney General's Office. And I will try to put this closer to me. I should have brought an assistant to do this at the same time. But I'm just briefly going to go over what our unit does and how it touches these issues. I also provided to you like one-pagers that basically describe our unit as well, that are included with that, as well as our CFR that is our guidelines from the federal. Since we're predominantly funded by the federal government, we have restrictions and guidelines on exactly what kind of cases we can do. But I'll get into that in our presentation. Maryland's Medicaid Fraud Control Unit was one of the first in the country and started in 1979. By the 1990s, it became a requirement that every state that had Medicaid, that accepted Medicaid funds, had to have a Medicaid fraud unit. I believe it was either North or South Dakota was the last to come on board. We now have 53. We changed our name in 2023 to the Medicaid Fraud and Vulnerable Victims Unit to reflect the fact that we do cases of abuse and neglect in the unit and just not Medicaid control. So we have a three-part mission in our unit. We fight Medicaid fraud, which would be healthcare fraud, which you would see when someone's billing Medicaid for services not rendered, that kind of thing. We also prevent abuse and neglect in group homes and nursing homes and assisted living facilities, as well as address drug diversion and what you would commonly know as pill mills. What we don't do is we don't do recipient fraud, where someone who is receiving Medicaid benefits, we do not prosecute them. We do not do financial exploitation of older adults outside a Medicaid nexus, except in an assisted living facility setting. And we don't do resident-on-resident abuse. We do civil and criminal. In my unit, as deputy director, I have 10 teams. 2 are dedicated specifically to abuse and neglect. The others are civil and criminal enforcement for healthcare fraud, drug diversion, and theft. And we also monitor what you know as key TAMs, the whistleblowers statutes, and we coordinate with other states to do those, but we have several hundred of those that we monitor as well. One thing I will touch on that you talked about with the nursing homes, when we saw this problem with the backlog with the surveys a couple years ago, when myself and the director, Zach Shirley, came on board as director and deputy director, we got a little creative in looking at that problem, and we started a what we call a strike force, where we go into problem nursing homes. We bring other state agencies, OHCQ, APS, as well as a local ombudsman, and we descend upon a nursing home and basically investigate the allegations of abuse and neglect, interview residents, collect records and do a thorough examination of the nursing home. We've done 4 of such cases since then. The legal theory behind that is that we shouldn't be paying Medicaid funds for worthless services. So if it's not adequately staffed, they're not getting, residents are not getting taken care of properly, we look at it as a fact that why are we paying you money? And so we have done 4 of those so far, civil cases. Ellicott City Nursing Home, Elkton Nursing Home, Patapsco, and I believe Orchard Hill, which is in Baltimore County. Most of them resulting in $400,000 or more in fines. And then we use that money to have them hire an independent monitoring agency that will monitor that nursing home for the next 3 years to make sure that they're complying with the adequate care and the residents. So it's kind of a novel approach, and we're trying to think about how we can do that in the assisted living arena as well. These are just a few of the statutes that we utilize in our unit in terms of prosecution and civil enforcement. And this is the provision that I was very, I wanted to close this loophole when I first came on. This was a couple years ago, and we came before the General Assembly to add that abuse, neglect, and exploitation there, but prior to that, the statute basically had a loophole that if the assisted living facility that was unlicensed applied for a license, it stopped all investigation. And if you had some crafty people out there, and it was a way to stop us being able to get in the door and pursue the cases. So we're happy that we closed that loophole, and we utilize that now in terms of our prosecutions. And then just briefly at the very end, I have here the CFR that basically shows what we're bound by the feds in terms of what we can and cannot do. So it does allow us to investigate abuse and neglect in assisted living facilities and in nursing homes. But there has to be some kind of like Medicaid nexus in terms of the nursing homes. Assisted living facilities, we can certainly get in to, and we also do exploitation as well. Sometimes we have residents where their funds have been stolen, and we've pursued those cases as well and prosecuted them successfully in my unit. I'm here for any other questions that come up with regards to future cases. I will point out to the committee that we don't just get referrals from OHCQ, we get referrals from everywhere, majority of them being private citizens. We have an online abuse portal that they can come through, as well as we work closely with APS and other state agencies to get referrals in terms of dealing with abuse, neglect, and assisted living facilities. And we also reached out to Baltimore County specifically, and we have worked with their fire department and zoning department to address unlicensed facilities, because that's usually when you see them, when the fire department comes in and it's a private home and they're not licensed, and they see people laying on the floor and mattresses and stuff, and we get cases that way as well that we are pursuing. So, thank you.
Thank you very much. And if I could ask the same of you, we're going to bring up Dana Kaufman, and then we'll open up for questions after this presentation.
Thank you very much, Madam Chair, Madam Vice Chair. My name is Dana Kaufman. I'm here today on behalf of Lifespan Network, which is a senior care provider association that has a very large, we're the largest representatives of the assisted living community. And I think we can bring an interesting take. Oh, usually nobody has any trouble hearing me. I think we can bring an interesting perspective to this issue. First of all, I think it's important to know I'm here not because our membership actually represents the very large assisted living, but the assisted living industry is essential across the board. And we are very concerned about the assisted living and making sure that the state has enough providers to provide the care that that is needed in the community. What we've heard before is a lot about enforcement and enforcement, but I think that this enforcement issue also gives us a very good opportunity to step back and get a better understanding of how we got here as well. So one of the things I want to make sure that you leave here with is knowing a better picture of the assisted living community. So I took a look at the directory, and you've heard me say this before. So of the licensed assisted livings, because frankly, until you're licensed, you are not an assisted living program in this state. So we keep saying unlicensed assisted living program, but that actually doesn't exist, because until you're licensed, you're not an assisted living program. But 16% of the industry is 2 to 4 beds. 5 to 9 beds comprise 58% of the industry, and then over 10 is the remainder. So when you look at that, 74% of the providers in the community that are licensed are 9 beds and under. So at the end of the day, the assisted living community really are small businesses. But the state back in 2003 took the position that everyone has to have the same regulatory requirements. So regardless if you have 2 beds or you have 150 beds, the same regulations have to be met. And that is very difficult for very small providers. We have tried to work with that community, and it is very hard because many of them are owner-occupied or owner-operated. So we think that when we're looking at this, Maryland right now has a senior housing crisis. We do not have enough senior housing options, especially for low income. And we need to be very judicious that when we're looking at this issue, we are building up our communities, but not losing our communities. Because if we lose assisted living providers, and it's hard to say this, but it's true. Just because you are unlicensed doesn't mean you are providing bad care. Some people just don't know that they are supposed to be licensed because they're caring for 2 or 3 people, that they had referrals from their church or their community or friends because Miss Smith needs a little bit more care and you now have the room. So we need to work with those folks. We need to get them to understand, but I think as a state, we need to stop and step back and take a look at our regulatory structure. Back, like I said, in 2003, there were, probably year-long meetings of whether or not we should have different tiers for providers, whether or not it should be based on size or based on the care that you are providing and the health needs of your residents. At the end of the day, we did a one-size-fits-all. Lifespan didn't think it worked. We don't think it works now. What was very interesting about that is that I remember, and I was still there, I think I'm probably the only person left that were still in those meetings. The Department of Human Resources runs a program called Project Home. The acuity levels might be a little bit different, but it's still caring for vulnerable individuals. And they were exempted from the assisted living regulations at that time because they said that they couldn't afford to operate under them. So what I would ask is, I think it is a good opportunity to look at our regulatory structure, especially when it is looking at these smaller homes that are caring for lower income. Other states have different classifications. Pennsylvania has assisted living. They have personal care home. It's based on the care. Other states, Rhode Island, New Jersey. I think we need to have that comparative look. I also think we need to take a look at our waiver program, our community options waiver. We have very few assisted living providers who participate. Why is that? I can tell you, the reimbursement is ridiculously low. They can't afford to participate in it. Also, the administrative requirements are too high for these small providers. They can't afford, and it's too much. But also, 3, for the clients, the wait list, they don't get off the wait list. The only way they can go into it from the community assisted living is to go to a nursing home first. We have to take a look at that, and we have to build up this availability of providers. So I think that those are the top two things that I would strongly encourage this committee to take a look at. It's not going to be fixed overnight, but we need to make sure that going into the future, especially given the fact that the senior population is the fastest growing population in Maryland, that we have the services that they need, and I can guarantee you right now that we do not. But we do have the Department of Aging who is working on this as well, which I know you're going to hear from next. So thank you very much for your time.
Thank you very much for your presentation. And if I can ask, as my predecessor, now speaker, always did, if I can get everyone to come to the table. We're going to open it up for questions. To our members, if you can direct your question to who you would want to respond, because I know we had a lot of presentations. And I'm going to start with Delegate Morgan, because I know you had your light on, and I did write it down.
Thank you, Madam Chair. My question was for Ms. Sullivan and AG. You cleared up a lot of it. But on page 13 of your slide, you talked about of the 120 complaints, 13 of them turned out to be unlicensed. Did you have to close any of those facilities down? Or what happens during, when you're found to be unlicensed, during that interim where they're trying to be licensed, I guess, or?
Yeah, and just so to reiterate, right, so we get complaints, do the investigation. If they're determined to be unlicensed, their first is that evaluation for any immediate imminent harm, right, whether it's a medical need or whether it is evidence of abuse, neglect, or exploitation, in which case that escalates the pathway that I talked about. For those that are not and are cooperating with the investigation, then they have 30 days to come into compliance, which is either to submit an application for licensure or to close or relocate residents. And we did find for some of those that they did end up closing. Volunteer, I mean, right, because they have that 30-day with the notice of violation, either again to apply for license or to relocate residents and close down.
All right, thank you, Madam Chair.
Delegate Ross, followed by Delegate Alston.
Thank you, Madam Chair. So I had two questions, if that's okay. The first one, and I agree, you did clear up a lot of the questions that I had. Thank you. So you talked about the coordination with the fire department and with the local governments, because that's really important. One of my questions about that, though, whenever there's an assisted living facility in Baltimore County, or I would imagine in any county in Maryland, you do go through a process to get a permit to operate. So I was wondering if you know from the beginning that this particular business is permitted to operate in the county, do you then get notified in some type of way? How close is that coordination? I did have a facility in my district that was up and running. They were duly permitted, but they didn't know there was this whole other process apparently that they needed to follow to get the license that they needed to have. So, and we did find out about that from the fire department. So you're right, they are the first to know a lot of the time. So how close is that coordination? Do you know from the beginning somebody has gotten permitted, there's this new facility, and they need to get licensed?
No, we don't. Sorry, this chair is broken. I'm sitting in the broken chair. But no, we don't know in the AG's office. I mean, I will say I have 47 employees that deal the whole state, right? So I only have 10 teams and only 2 do abuse neglect. And we're reactive. So we get complaints from everywhere. So we would not get that. The things we get from the fire department are when they find abuse neglect, when, like I said, they find someone laying on a mattress or in bad conditions. You know, and we agree with, actually with Lifespan and with OHCQ in terms of, we know there's a problem with housing, you know, and the lack of housing and we don't want to discourage good providers out there. My unit's more focused on the bad guys and getting the bad guys out of the system. So it's kind of hit or miss with the zoning and fire departments, and some counties are better responding to us than others.
I just feel like the back end of the process works very well, like what you do, and even when OHCQ refers to you, all that works well, but the front end of that process is absolutely ineffective. Like, it is totally whistleblower based. So it's got to be people in the public knowing what to look for and then taking the time to report it. And sometimes they call us. Like, I've gotten those calls. I was at a nursing home facility not too long ago. I was at a homeless shelter not too long ago. And that was all whistleblower based. And then I was able to intervene and pull in the right stakeholders. So I feel like the front end of that, I don't know if there's anything more that you can answer about that here today or just think about it for later, but that OHCQ can do to surveil or monitor or somehow, you know, be on top of those kinds of the issues and flags that people need to look out for. Maybe there's an awareness campaign to tell us what to look for.
We do outreach, I will say, from our unit, but I will also say that we are working, they mentioned the work group that they just put forth. We're a partner in that.
That's great.
So we are looking for all kinds of creative ideas.
Yep,
And
thank you.
if I can just add, I think for this work group, one of the very first questions that the work group was asking, again, with all of the partners at the table, is this question of, you know, what are the barriers to becoming licensed? And is there some things that we can do, right, to facilitate that, I think, to what you're asking? And then, you know, on the flip side, are there reasons that someone would be unlicensed? And again, how can we address it? And so I think these are the exact questions that we are really digging into and trying to address from a statewide perspective.
Yeah, that's good. Thank you. Thank you, Madam Chair.
Thank you. I have Delegate Alston, followed by Hill, followed by Riley.
Thank you, Madam Chair. Thank you, Madam Chair. So my concern is the chilling effect that overregulating the smaller homes is having. And I'm curious, do you have any data, either Ms. Kaufman or anyone else at the table, about the number of closures that we've had? Because we know that we have a deficit, but this treating these smaller homes as if they are a full-fledged nursing home is not appropriate, and we are losing people. I have a friend that owns an assisted living who is on the brink of closing down because of the over-regulation. And it's regulation that's not even appropriate for the type of business. So if you could talk to the chilling effect that some of these regulations are having that are not even helping with safety issues, it would be really helpful to us as we make our decisions.
It's not red.
Well, I can speak a little bit about that, but I don't have any data. But that is where our concern is. And you also have to remember that, well, years ago, the state actually had a category of, you know, domicilial care, which I think we need to really revisit. That was the point I was trying to make. But to your point as well, we also have to remember that come July 1st, all assisted living managers have to now be licensed as managers by the Board of Long-Term Care Administrators. And I'm concerned that there is a lot of these small providers who are licensed, but just don't recognize that requirement. But in order to be able to be licensed, they also have to now take the 80-hour assisted living manager course. Before, our smaller homes, the 2 to 4 beds were exempted. And then when the manager course came, I'm sorry, when the licensure for managers came about, that was changed. That is an expensive course, and it is a very detailed course. It's 80 hours. So again, you can't be licensed until you take that course. So I think that, to your point, there is concern too with these smaller homes that, you know, have we over-regulated them? Have we actually created this situation that we're in now by trying to do a one-size-fits-all? One-size-fits-all rarely works for any industry, and especially doesn't work for this one. So, and I think that's what we're seeing too.
And I think what is, these are the questions and conversations that we are having too. We were literally just talking about this yesterday. We're simultaneously, you know, during the previous briefing on nursing homes, we're talking about needing to ensure quality and really looking at for every individual patient. We need to have the standards in place so that that patient is safe and healthy and is aging or has care with dignity, while at the same time, right, understanding some of the nuances. And we do not want to create a barrier to licensure or certainly to some of these places. And, you know, I think we're having these conversations and really trying to think about how we find that exact, right, sweet spot. I, started off by saying this is really complex, but what I can tell you is these are, the conversations that we need to be having, again, with the ultimate goal of trying to increase the supply overall of safe and affordable housing for older Marylanders.
And I never get the chance to do this when I'm actually testifying on bills. But, one of the things, too, I think that when we're looking at this is really trying to also realize what continued tools and resources can we provide to these smaller homes? Because I think sometimes they want to do the right thing, but they don't know how, but they're also afraid to speak up because they're afraid of punitive actions. So I think trying to figure out what resources and tools that we can provide to them just throughout the process would also be very, very helpful.
Thank you very much for that insight, too, because I don't think it escapes anyone's notice that we now have a subcommittee on elder and long-term care because we really want to put, sunshine on the care continuum for our elder and aging population. Delegate Hill, followed by Delegate Riley.
Thank you. I'm actually smiling, Dana, because I think you anticipated my question because you didn't want me to ask one. So first, for you, a point of clarification, and then for Madam Secretary, the question. Clarification, when we're talking about the size, are we talking about per site or per owner? So if I have 3 sites, am I licensed by the number of total beds or the per site?
It's per site.
So I'm going to pay a fee for each site?
Correct.
Okay, and it looks like the fees aren't bad. They're $50 a year, up to $350. Madam Secretary, so to Dana's point, why would I be licensed? Why I mean, what are you doing to help me? Are you helping me with my staffing? Are you promoting me? Or is there a registry where people notify me? What are you doing to help? Why bother to be licensed?
Yeah, I mean, I think it's a great question and one that we're grappling with. OHCQ is a regulatory agency, so I think even just that name, right, doesn't scream, right, helping. It really is about punitive action. But I would say we try and take that seriously. I think the regulations that were just updated really were done with patient safety first and foremost and quality, but also I think to help the residents. I actually to help the owners, I should say. Very early on, I went on an inspection of it. It was a licensed facility of a complaint, but I wanted to see firsthand what I did and saw some of the complexities. It was a smaller facility going through some of the new regulations, but really saw the staff working with the owner to say, here's the underlying goals. How can we help you meet these regulations? And I do think that I've seen it firsthand. OHCQ staff are trying to approach it from that perspective too. I think I really appreciated what you said about for many of these facilities that are unlicensed, it is not that they're providing wrong care. It is, I think some of the other reasons, and everyone was approaching it with the trying to do what is right. I think that there is a reason that we have regulations in place because they're based on what is safe and what is best, but we do try and approach it from that perspective. I think the question of, though, is there more that we, and again, kind of thinking holistically can be doing is a great one and one we should be asking.
Okay, and just so you know, I think we've done the same thing in childcare as well, right? Making it hard. Thank you.
Delegate Riley.
Thank you, Madam Chair. I, too, after listening to the presentation, thank you. It's been very helpful and useful information, but, too, concerned about the over-regulating, especially like our small homes that we certainly do need with the growing elder care. So after after the work group, I heard you probably will be submitting a report for recommendations. I'm assuming the recommendations come through legislation. Is there currently any legislation that you're aware of this year that will be talking or addressing some of the problems that you found in this work group? And then just to follow up to that, if not, will there be new regulations that has already been drafted and coming forward? And if so, can you explain what that process is when you come up with regulations? Because obviously it doesn't come to the legislature. It's inter office. So do you take providers in consideration? Is it going to go through the same work group, or is it just the administration? I don't know. So if you could I know it's kind of like 3, Madam Chair, but they're all the same. Thank you.
No, and I will tag team on these and then let us know also if we forget one. But I think first and foremost, just to talk about the work group, we're really looking at a few different things. I think the first is, right, what are our protocols and policies for when we are receiving, whether it is complaints or information about unlicensed facilities, how are we approaching those and doing everything that we can to do with interagency coordination, again, recognizing how important our partners are, and how do we make sure those are as standardized as possible. The second thing that we are looking at is, and we talked about this in the nursing homes, around transparency and public reporting. And, you know, when we've been asked a lot of questions around if somebody is running an unlicensed facility, you know, what are we saying, where do we publicly, what can we say within the statute? So looking at that and what we can be doing. The third, and I'll get to your question. Third, again, the broader question of increasing the supply of safe and affordable housing. And then the fourth place is, are there policy, regulatory, or statutory changes that we do need? I spoke a little bit about the statute. It was strengthened in 2023, again, with the support of the Office of the Attorney General and the Department of Health, but I think we still see some areas that are creating some of these questions. And so this work group is really digging into whether or not there are changes that we would bring forward, but need a little more time to do that. And then the question about regulations, correct, that was the second one. I think we can speak a little bit more about the regulatory process. We'll say I do know, and having done this at different levels, it does, it's usually based on a statute or legislation or work that we're doing. It is involves a lot of stakeholder feedback. There's a public comment period where we need to kind of address and decide or respond to every public comment, and done in a pretty transparent way. But I don't know if you want to add anything.
No, I think the only thing that I would add to that is that during that comment period, we are also working with our stakeholders like Ms. Kaufman, who gives us lovely recommendations of things that we can do and how we can improve upon that. So we really do try to include everyone who is impacted by the regulation.
Thank you very much. Seeing no further questions, we're going to go ahead and conclude this briefing. We do have another briefing following. So for planning purposes, you can go ahead and take us home. Thank you. For planning purposes,